We are currently living through the deadliest addiction crisis in human history. But while families are devastated and communities are hollowed out, a very select group of investors is quietly minting billions. Let's stop pretending the rehabilitation industry is just a noble, charitable crusade. It is a ruthless, fiercely competitive, and wildly lucrative $42 billion machine. And here is the deeply uncomfortable truth that the industry desperately wants to keep hidden. In the business of rehab, a permanently cured patient is a lost customer. When industry-wide relapse rates hover anywhere between 40 to 60%, you aren't just looking at a medical tragedy. From a purely economic standpoint, you are looking at a built-in, recurring revenue model. So, who is actually cashing in on the crisis? What does it really cost to open the doors of a luxury treatment facility, and how exactly do insurance payouts, out-of-network billing loopholes, and urine testing turn human desperation into astronomical profit margins? Today, we are stripping away the sanitized brochures, the wellness jargon, and the PR spin. We are going to break down the exact math, the dark incentives, and the staggering economics of owning a rehab center. By the end of this, you will understand exactly how the money flows, and you will never look at the recovery industry the same way again. To understand how we arrived at this point, you have to look at the historical catalyst that turned addiction treatment from a community-based support system into a Wall Street gold rush. For decades, rehabilitation was largely the domain of state-funded asylums, church groups, and 12-step programs. Private insurance companies historically refused to cover addiction treatment, viewing it as a moral failing rather than a medical necessity. But everything changed with two massive pieces of legislation: the Mental Health Parity and Addiction Equity Act of 2008, and the Affordable Care Act. Overnight, insurance companies were legally mandated to cover substance abuse and mental health disorders at the same level they covered medical and surgical procedures. Suddenly, millions of people who previously had no way to pay for a $30,000 month-long stay in a facility had insurance policies that were legally required to foot the bill. The government effectively opened a multi-billion-dollar spigot of insurance money, and entrepreneurs, real estate developers, and venture capitalists rushed in to catch the overflow. Let's talk about the buy-in and the barrier to entry, because you might think opening a medical facility requires a medical degree, decades of clinical experience, and a pristine moral compass. It doesn't. In many jurisdictions, you just need an LLC, a zoning permit, and a building. You don't have to be a doctor, you just have to hire one. The initial capital required is steep, usually anywhere from $500,000 to over $2 million just to get the doors open. Why so high? Real estate and the relentless resistance of local communities. Neighborhoods will fight tooth and nail to keep a treatment center out of their zip code. As an owner, you are paying a massive premium for properly zoned real estate, or you are funding a costly legal war with a suburban homeowners association. But venture capitalists and private equity firms happily write those $2 million checks every single day, because the return on investment can completely obliterate almost any other traditional real estate or healthcare play. To bypass these strict residential zoning laws, clever operators popularized what is known in the industry as the Florida model. Instead of trying to zone a massive, 30-bed medical facility in a quiet suburban neighborhood, which is nearly impossible, an owner will rent or buy a cluster of standard residential houses. These are designated as sober living homes. Because of the Fair Housing Act and the Americans with Disabilities Act, recovering addicts are considered a protected class, meaning local governments have a very difficult time preventing a sober living home from opening in a residential neighborhood. The patients sleep and live in these lightly regulated residential houses, and during the day, they are loaded into 15-passenger vans and driven to an office park in a commercial zone for their actual clinical therapy, known as Intensive Outpatient Programming, or IOP. By separating the housing from the clinical treatment, owners bypass medical zoning laws entirely while still billing insurance for high-level care. Let's stop dealing in abstract concepts and look at the actual spreadsheet. We are going to build a hypothetical 30-bed substance abuse treatment center, not an ultra-luxury Malibu retreat with equine therapy and private chefs, just a standard mid-tier facility in a quiet suburb. First, let's look at the gross revenue. A standard 30-day inpatient stay runs about $20,000. If you keep those 30 beds full, what the industry calls 100% census, you are grossing $600,000 a month. That is over $7 million a year in base revenue. Luxury facilities easily push this to $50,000 or $100,000 per bed, often paid entirely out of pocket by desperate families maxing out credit cards, taking out second mortgages, and draining retirement accounts. But the real secret to the astronomical profit margins isn't the bed. The bed is just the loss leader. Once you factor in the intensive outpatient programs, the specialized therapy billing, and the relentless stream of medical testing, a well-optimized facility can easily push that gross revenue past $10 or $12 million a year. The true financial engine of this industry is what happens in the bathroom. Welcome to the incredibly lucrative world of urinalysis. For years, rehab owners quietly referred to urine as liquid gold. A simple, point-of-care, plastic cup-based drug test costs the facility roughly $10 to administer. It gives an instant read on whether a patient has drugs in their system. But rehab centers realized that if they sent that same urine sample to an outside laboratory for complex analysis, using a process called gas chromatography mass spectrometry, they could bill out-of-network insurance providers for astronomical sums. That $10 cup of urine was suddenly being billed to insurance companies for $500, $1,000, or even up to $4,000 per test. Now, do the math on a 30-bed facility. If you test 30 patients 3 times a week and bill the insurance company $1,000 a pop, you are generating nearly $100,000 a week, purely in urine testing. It became so insanely profitable that rehab owners stopped sending the samples to third-party labs and started opening their own laboratories, or entering into shady joint ventures, capturing the entire profit margin. Doctors were pressured to order complex lab testing not because it was medically necessary for the patient's recovery, but because the facility needed to hit its quarterly revenue targets. Insurance companies eventually caught on to this and have spent the last few years aggressively trying to cap these payouts. But the underlying strategy of the industry remains untouched. Drain the patient's insurance policy for every possible dollar until the maximum lifetime payout limit is hit. So where does all that revenue actually go? You would assume a medical facility's biggest expense is elite medical staff. It isn't. By law, you need a medical director. But in most states, they don't have to be on site 40 hours a week. Many rehab owners pay a local psychiatrist a flat retainer, perhaps $5,000 to $10,000 a month, just to review charts, sign off on treatment plans, and lend their medical license to the facility. The people actually running the floor 24 hours a day, managing patients through the worst moments of their lives, dealing with night terrors, withdrawals, and emotional breakdowns, they are called behavioral health technicians, or BHTs. They are often paid $15 to $20 an hour. In many cases, they have absolutely no formal medical or psychiatric training. Many of them are actually former patients who are just a few months into their own recovery. The industry runs on cheap, entry-level, highly vulnerable labor. Your real overhead costs are real estate, liability insurance, food, utilities, and administrative staff. For our 30-bed facility, that basic overhead sits at around $200,000 a month. At this point, you are grossing $800,000 a month and spending $200,000. It looks like you are printing money. But we haven't talked about the single biggest, most volatile, and most cutthroat expense in the entire rehabilitation industry: the acquisition cost. How do you keep those 30 beds full? You have to buy your patients. In the business world, this is called customer acquisition cost. In the rehab industry, it is a bloodbath. When a desperate parent discovers their child is using heroin, they panic. They go to Google and they type "drug rehab near me" or "addiction help." They aren't researching long-term clinical outcomes or cross-referencing medical licenses. They are terrified, and they are clicking the first link they see. Rehab centers know this. They bid against each other in real time for those exact keywords. The cost for a single click on Google Ads for highly targeted addiction terms can skyrocket to $50, $80, or even over $100. Not for an admitted patient, just for a single click on a website. A competitive treatment center will easily burn $50,000 to $100,000 a month purely on digital marketing, SEO, and paid search. The links at the top of Google rarely lead to a doctor's office. They lead to massive call centers. These boiler rooms are staffed by salespeople working on quotas and commission, staring at CRM software. Their entire job is to keep that crying mother on the phone, assess the quality of her insurance policy, and convince her to put her son on a plane to their specific facility that very same day. If the caller has a premium PPO insurance policy, they are treated like royalty. If they have Medicaid, state funding, or no insurance at all, they are often quickly rushed off the phone or referred to state-run wait lists. Because a fully insured patient can be worth $50,000 to $100,000 in billable services over a few months, the staggering cost of Google Ads birthed a shadow economy. This is where the industry takes a truly sinister turn. To keep the lights on and the profit margins high, you need heads in beds. An empty room is burning cash. Enter the patient broker. Patient brokers are essentially bounty hunters, operating in the gray areas of the law. They scour AA meetings, loiter outside of methadone clinics, infiltrate Facebook support groups, and walk through homeless encampments. They get paid illegal kickbacks, often $5,000 to $10,000 a head, just to recruit addicts and deliver them to a specific facility. The broker acts as a terrifying travel agent. They offer the addict free plane tickets, free rent in a sober living house, free groceries, and even cartons of cigarettes, just to agree to go to a specific rehab center. Once the addict is checked in, the facility bills their insurance for tens of thousands of dollars, pays the broker their secret cut under the table, and the cycle continues. This process became so rampant in places like South Florida that it earned a grim nickname, the Florida Shuffle. A patient from Ohio with a good insurance policy is flown down to Delray Beach. They go to rehab for 30 days. The insurance is billed. The patient is released to a halfway house. And here is where the darkest incentive of the entire economic model reveals itself. In the most predatory corners of this industry, brokers and corrupt halfway house owners will actually supply recovered patients with drugs, specifically so they relapse. Why? Because a cured patient generates no more revenue, but a relapsed patient can be readmitted. They can be sent to a new facility, completely restarting the insurance billing cycle from day one. The urine testing starts again. The intensive outpatient billing starts again. The addict is bounced from facility to facility, from sober living home to sober living home, slowly having their insurance policy drained like a battery until the maximum payout limit is hit. Once the policy is empty, the free rent stops, the free flights stop, and the patient is unceremoniously dumped onto the street to make room for the next insured commodity. The addict is no longer a human patient. They are a renewable financial asset in a terrifying loop. This isn't just healthcare. It is a high-stakes, ruthless industry where the underlying asset is human desperation. Let's do the final math on our hypothetical facility. $10 million in gross annual revenue, $2.5 million in facility and staffing overhead, another $1 million burned on Google Ads, call centers, and marketing. Throw in $1 million for administrative bloat, legal fees, and compliance. You are left with roughly $5 million in net profit. That is a 50% margin. In traditional healthcare, a massive hospital network is absolutely thrilled to make a 3 to 5% operating margin. That staggering discrepancy is exactly why Wall Street, private equity firms, and massive holding companies are currently rolling up the industry, buying mom-and-pop rehabs by the hundreds and consolidating them into massive corporate portfolios. They aren't pouring billions into this sector out of a deep desire to cure the human condition. They are in the business of securing a 50% margin on a chronic disease that has no guaranteed cure. After looking at those profit margins and the sheer scale of the exploitation, it is incredibly easy to become cynical and assume the entire rehabilitation industry is just a predatory cash grab. It isn't. There are thousands of dedicated clinicians, social workers, and ethical facilities actually doing the grueling, heartbreaking work of saving lives. But financially, they are playing a completely different, infinitely harder game. Ethical facilities, often operating as certified nonprofits or community-based organizations, do not have access to venture capital or private equity funding. They do not have marketing budgets to outbid corporate giants on Google Ads. They survive through a patchwork of revenue streams that are far less lucrative than draining out-of-network private insurance policies. These ethical centers rely heavily on state and federal grants, Medicaid, Medicare, and community fundraising. Because they accept government money, every single dollar is tracked, audited, and strictly regulated by the agencies providing the grants. There is no room for $500 urine tests or phantom billing. Furthermore, in a nonprofit model, there are no shareholders demanding a 50% return on investment. If the facility somehow manages to generate a surplus, that money is legally required to go right back into patient care, staff training, facility upgrades, or community outreach. Ethical facilities usually charge on a sliding scale based on what a patient and their family can actually afford, rather than reverse engineering the cost based on the maximum limit of an insurance policy. But there is a brutal trade-off to this ethical model. Because they aren't generating $50 million corporate valuations, these centers do not have oceanfront properties. They do not have private chefs, massage therapists, or luxury equine therapy. The buildings are often institutional and heavily worn, and most importantly, because they are deeply focused on providing actual, sustained clinical care rather than fast, 30-day turnovers, they are almost always operating at maximum capacity. The wait lists for state-funded or highly ethical nonprofit beds can stretch for weeks or even months, a delay that can be a literal death sentence for someone dealing with a severe fentanyl or heroin addiction. This reality leaves families in an incredibly dangerous position. If you or a family member are ever in the devastating position of looking for a treatment center, you can no longer afford to simply trust a glossy brochure, a comforting website, or a soothing voice on the other end of an 800 number. You have to become a forensic accountant. You have to look past the promises of healing and examine the financial DNA of the facility you are considering. You must demand transparency before signing over a single dollar or handing over an insurance policy number. The first thing you must establish is their relationship with your insurance. Are they in-network? If a facility refuses to work in-network with your insurance and insists on billing out-of-network, you should immediately walk away. Out-of-network billing is the absolute engine of the financial loopholes and the exorbitant testing markups. In-network facilities have pre-negotiated rates and are subject to much stricter oversight by the insurance providers. Second, you have to ask who actually owns the facility. Is it a community nonprofit that has been operating in the same town for 20 years? Is it a dedicated medical group run by actual physicians? Or is it an LLC owned by a private equity firm that bought the facility 6 months ago with the intention of flipping it in 3 years? You also need to ask extremely uncomfortable questions about their medical protocols, specifically their drug testing policy. Ask them explicitly how often patients are tested, which laboratory the tests are sent to, whether the facility has a financial stake in that lab, and what the exact billing structure looks like. Ethical rehabs test for clinical reasons to monitor a patient's health. Predatory rehabs test for financial reasons to extract maximum revenue. Finally, analyze how you found them. If you called a generic helpline from a sponsored Google search, and the person on the other end aggressively pressured you to book a flight that same day, repeatedly asked about your insurance deductibles before asking about the patient's medical history, or offered to pay for your travel expenses, you are likely talking to a call center or a patient broker, not a medical professional. Addiction is a catastrophic medical and social crisis that is tearing apart the fabric of communities across the globe. But we have to stop pretending that the infrastructure built to treat it is somehow immune to the cold, calculating laws of modern capitalism. The rehabilitation industry is exactly that, an industry. It is driven by shareholders, quarterly earnings reports, acquisition costs, and profit margins. And as long as the current financial incentives remain legally in place, treating a patient will always be inherently less profitable than keeping a customer. The good facilities are out there, fighting a daily, exhausting war to keep people alive on razor-thin margins. But they are operating in the shadow of a $42 billion machine that has figured out exactly how to monetize human desperation. Until the regulations fundamentally change, the only defense you have is to understand exactly how the money flows. Do not just look for a cure. Look for the financial motive.